All right, we are recording and it's episode 4. So we are going to be over the hump today in our 7-part mini series. Today we're going to measure everything. So this is an exciting one. I like this one.
It's a fun one. I mean, we say this about every episode that we get really excited about it, and this is super important and super controversial and polarizing. But yeah, I mean, we'd be in the wrong field if we didn't get excited about every one of these episodes. So we're getting into it. Episode 4. Hopefully more than mom and dad is listening. Last podcast got 6 listens, so we are moving on up in the world. And yeah, we're just going to keep recording, and whoever listens.
Man, everything starts somewhere. So we'll just see what happens. But look, I really enjoyed last week, actually. I think that was a very important topic. But it's, definitely one of my favorites. And, this week is as well, I think. But last week was great because it really shines a light on the details, and today will as well. But I think that's a big part of the difference. And I like the details. I know it's probably not everyone's cup of tea, and we've sort of talked about that, but that's what makes it special.
Well, if you're a physician, it should be your cup of tea.
Yes.
Flat out. So that's my 2 cents on in that regard. And we're measuring everything today, and the gentlemen out there listening understand the importance of, a nice measurement every once in a while, just to make sure that everything is in tip-top shape, if you know what I mean. So we're going to be resonating with maybe 49% of our target market, and we should be in good shape.
I really love the movie Step Brothers. Is that a film that you enjoy?
I do enjoy Step Brothers.
Right, it's up there with my favorites. And so when we got to this topic today of measuring everything, and I'm taking the show right down into the gutter straight off the bat. So apologies to the viewers and listeners, but the first thing that jumped into my head was that scene in Step Brothers where they become best friends and they're running up and down the stairs and they're doing karate in the garage. And then the next thing they're crossing swords in the bathroom, pissing over each other. And then they get the measuring stick out and they check to see if the old fella's the same size, which it is. It's exactly the same. So there you go. That's measuring everything.
If you haven't taken a ruler or a yardstick or whatever you want to call it, I don't know what they call it down under, a meter stick to measure.
It's a ruler, yeah.
The ruler. Once in your life, if you haven't done that, you're full of shit. So. But speaking of, I don't know if I want to say more important things to measure, but more relevant things to measure for the topic of this podcast. Kind of explain to the listenership out there what we are measuring and why it's so important to be measuring. And you can touch on that from a patient perspective standpoint. You can touch on it from a physician perspective standpoint. So what are we measuring and why are those measurements important?
Yeah, I think measurements are important. It doesn't matter what you're doing. I remember, 100%. And if I remember back to, when I did my first CrossFit workout, for instance, and you realize that you could take measurements on fitness because that was how you measured if you were getting more fit, if you were progressing, if you were getting better. And so you could take your time, you could take your strength data, you could take all that stuff, and then you could go and retest that benchmark workout and see where you're at compared to where you were before. You can see if your strength numbers are progressing. You've got all these metrics to be able to see, am I better off than where I was before? And that kind of blew my head off when I realized that we could do that with fitness. That was very exciting because I think I'm someone that likes numbers, and not everyone does, but it gives you something very tangible, something to be able to work with. And we sort of talk about that now in terms of musculoskeletal health. And so it's, you know, we put that framework around measuring range of motion and measuring function, so that we have tangible things to be able to know, is something getting better? What's the state of it right now? Where are we at? How are we tracking? And it just brings a level of transparency to the whole thing. There's nowhere to hide, and there's nowhere to hide for us as the practitioner. We have to be good at what we do. And if we're doing a crappy job, then that is something that we can't get away from. And it also brings ownership to the patient as well, because, you know, they need to be doing their part in this engagement to be able to get the progress that they want. So, yeah, you know, to be able to put some numbers around these things, whereas perhaps historically it's been a little bit more just the how are you feeling today, which is still important. And, you know, that's data that we collect. It completes the picture. But actually being able to have measurable, observable data around how you move through space and the health of these different body regions and tissues, that's super important. And we measure it all because we need to, and we have to. It should be done.
Yeah, that's beautifully said. Yeah, I mean, the human brain is fickle, right? So it can lie to you in any number of ways. You know, you can trick yourself into feeling better. You can trick yourself into feeling worse. So when you're collecting data, right, there's always two types of data that you're looking to collect. There's subjective data and then there's objective data. And all other fields in medicine and healthcare are all looking to quantify and obtain objective data. You know, I have a client who's listens to the podcast, or so she claims listens to the podcast. I believe you, Debbie. So thank you for listening. She's a clinical psychologist. And so their way of obtaining objective data, objective feedback is through these questionnaires, right, that are scored and that can give you a tangible measurement. And they use those as progress markers, just like you would use your Fran time as a progress marker, because you can sit there and be doing CrossFit for 8 weeks and not really feel like you're more fit, right? Your brain, depending on what its natural wiring is, and I think we're all biased in the negative, but the degree in which you're biased to the negative probably fluctuates between individuals. So if you don't feel any progress and it's 8 weeks down the road and you didn't measure Fran at the beginning and you didn't measure Fran 8 weeks from now, your level of compliance is going to significantly decrease because all you have is subjective data, right? I coach nutrition as well. So it's not every week where you look in the mirror and you say, holy shit, I look different, right? I feel different. It doesn't happen every week. So what you have to do is collect data. In nutrition, a lot of times that data is raw weight. A lot of times that data is how clothes fit you, how many belt loops that you have to use, what your actual tape measurements are. So in a way, objective data is that kind of counterbalance to the subjective data. And it gives us a viewpoint from a different perspective that we can either use to say, that makes sense, or we can use to say, that doesn't make sense. And yeah, you have to measure everything from a patient compliance standpoint. And like you said, it holds you accountable. For the first maybe year and a half that I practiced, I didn't measure everything, right? I did what I was taught to do. And there were a lot of days that I went home and I sat there and I thought, and I was like, man, did I fucking do anything today, right, to help anybody? So yeah, it's good for patient compliance. It's good for measuring, how well they're improving, and it's good for, I don't want to say your ego, but it's good for your own psyche as a practitioner when you can say, yeah, I've improved this person's straight leg raise by 12%. So from a sustainability standpoint, as a practitioner, it's paramount. From a patient compliance standpoint, it's paramount, and there's a reason why it's the fourth principle.
Yeah, I like the idea. I think that you can't hide behind anything anymore, because, you know, those numbers, if you put them up on a whiteboard or however you choose to record that or make that visible to the patient at the time, yeah, you've got to be doing your job. So, and for a little while, I didn't probably have the confidence enough in the skill set to be able to know that that things were going to be able to be making changes enough, and that's developed. But, you know, so now I love that. I love being able to share that with people, and people generally get on board with that, and it turns into something that they're invested in as well. And so seeing that change over time, then I think that actually influences the decisions that they make, because they see that there's progress happening. And so if that, you know, turns into a load versus capacity type conversation or something, if we need to have a load management conversation, maybe the activity needs to change a little bit or something like that, you know, we can just lean on those numbers a little bit, and it just informs the whole thing. So it's a powerful thing. And I think, you know, getting back into this earlier on, it really, for me, it kind of filled a gap. It filled a picture, and it answered a lot of questions that I had. And I think you just touched on it before from earlier in your career. But it's one of the problems. And it's one of the problems that in our profession that we face, is that people are asked to believe a little bit too much. And it doesn't have that objectivity to be able to show. You know, there's something that we battle historically has been over-servicing. So, you know, people are probably getting sold things that they don't need, or perhaps over a duration that they don't need, that sort of thing. And this prevents that. I mean, it doesn't kind of prevent it. It does prevent it, because if someone's passing all their tests and the data that we're collecting is right where it needs to be, then we can't necessarily, you know, we can't sign them up to another intense period of treatment or something like that. So it protects everyone involved. All the stakeholders are protected in that sense, and it's a beautiful thing.
Yeah, I mean, that's easily the biggest criticism with chiropractic care is, you know, this guy's going to make me sign up, or gal is going to make me sign up for 24 visits and all this other stuff. How do I know this is actually helping me? You know, as we've discussed on this podcast before, you know, the difference between traditional chiropractic care and a pamphlet is nothing over the course of, you know, 4 weeks or something like that. And so we use these measurements to enable us to make intelligent decisions about changes to the care plan in a very real-time manner, right? So, you know, I'm not going to make you come in 2 times a week, 3 times a week, if your tests are now at 90% or at 80%, right? We know that once we start to hit 80% in the tests, I start dialing back the treatment frequency, and we're in good shape. We use it as a benchmark, you know, just as much as we use it to judge a treatment's efficacy. And, you know, when we start to look at traditional chiropractic care plans and, you know, what they're required from a maintenance standpoint, you know, there are people that do need maintenance care, right? They're not getting to 100%. And whether it's because they're metabolically damaged, whether it's because they're excessively loading the tissue, whether it's because there's arthritides that we're trying to prevent from progressing, right? I can use those measurements to then say, okay, the best we've ever gotten your straight leg raise is 85%. So I'm trying to find the greatest amount of time that we can put in between visits to where we can get you back to 85% and hold you there for the rest of your life. So they're used as benchmarks, and they're used as benchmarks for movements too. So, I'm not going to have anybody deadlift if their straight leg raise is less than 80% combined with their quadruped lumbar flexion. So it's like, now I can provide you some serious expert level load management. You shouldn't be running if your ankle dorsiflexion is less than 80%. You shouldn't be going overhead if your shoulder abduction is less than probably even 85 to 90%. So it just allows us to level up our game, allows us to be better at recommending both movements to you and treatment, I guess, frequency to you. It helps educate our corrective exercise selection, all those things. So just having that data and knowing how to interpret it, which is, I guess, more of a second level skill, it just helps us get you better in less visits, just in a more efficient way.
We can get into an example too and run through, maybe for the lower back, for instance, we can sort of run through what that looks like. I love the analogy of taking the blood pressure. I think it's a really nice way to kind of explain that as a snapshot, because we all know that taking blood pressure is something that we do to monitor cardiovascular health. And you would do that in someone that is perhaps at risk or is interested to know how that's changing over time and where they're at. And so that's a fairly simple thing to do. It gives you some pretty important data. And what's interesting about that is that that person may not necessarily be aware of a change in their blood pressure, and they may not be aware of things fluctuating. So that's why they have to take that test and they have to get that information. So if we kind of apply that to musculoskeletal and the lower back, for instance, we can essentially take that blood pressure and give that report as a percent of function. So we can come back and say, after doing this, you have X percentage of function in your lower back and hips. And that's a really powerful thing to be able to know, because a lot of the time that's going to be deficient somewhere in most people, and they're not going to be necessarily aware of that. It's going to be a sliding scale. Some people are going to have a little bit more range of motion in some areas compared to others. We're all a bit different. But it's often not something that you're aware of, because your normal daily activities are still going to get done. You could be in pain and you're sort of aware that something's wrong, but perhaps not. Perhaps it's just something that you've been able to alter some movement patterns around. So being able to highlight that and understand that, and then if you want to go and correct that, setting yourself up for more success later on, more longevity. And so it's a bit like taking your blood pressure for your heart and your cardiovascular system, where you're trying to, prevent something catastrophic happening later on. It's just applying that same concept, but we're doing it in a different system of the body.
Yeah, I mean, that hits home for most individuals, because they're familiar with the concept of blood pressure being a metric that measures the function of their cardiovascular system, right? Now, it may not, if you have high blood pressure, it may not pinpoint exactly what's going on, but it's sensitive to the fact that there is an issue somewhere in that cardiovascular system. And if you fix that issue, then your blood pressure should tangibly improve. So that's, in a nutshell, how we would use the function of somebody's lower back. And again, this is the fourth principle. So we're using the first three and then adding this fourth principle, which is the measurements, onto those first three principles to formulate the most, complete and clear diagnosis and picture of what's going on, right? We talked last week about how your diagnosis should be like 85% sure only after your history, where you're discussing symptoms, you're postulating about pathology, And so now when you get into the actual exam, and you go in there and then you do measure something, now that measurement has to go back and either, it has to confirm your pathology, it has to confirm or reaffirm your symptom set too. So is it adhesion? Well, we know that that's going to cause limited range of motion. Is there a joint tear, or is there a cartilage tear? Sometimes that causes a limited range of motion. Other times it doesn't. Other times it results in full range of motion with symptoms. So we circle back at that. Arthritis typically is going to cause a range of motion restriction as well. So it's like, okay, is the range, now we look at the magnitude of the measurement. Is it a 10% deficit, 20% deficit, 30% deficit, 40% deficit, 50% deficit? So, you're getting in there and you go and you measure somebody's hip and it's at a 50%. You go ahead and you circle that back to the symptom set, and you circle that back to, I guess their age and activity level, and you can pretty closely determine, even without a film, whether or not that it's an arthritis. So we're using it as a diagnostic tool as well, to either add data to our hypothesis or to kind of give us a little bit of pause and see if there's something that we maybe missed as well.
And it really has to be combined with the subjective data as well to create that picture. So that's why part of the check-in process through a consult is to get an update on the pain level, the pain score, I should say. So, that score out of 10, where are we at? We can still compare that. And that's still one person's experience. So it's very much, we were talking about like a CrossFit workout and maybe remeasuring benchmarks. An athlete might be having a really shitty day on one day when they do that benchmark, and, they might not feel great. They might feel absolutely blown up and terrible, but it's not necessarily a benchmark of their current fitness at that point. They might just not have had a really good sleep that night, and who knows what's going on. But, and pain levels can be a little bit sensitive like that too. So we do see some fluctuations, but we still need to capture all that data, because it's important to understand where someone sees themselves at that point in time in terms of how they're progressing. What's the percentage that you see yourself as being improved since we started? So some of these numbers, it's adding numbers to a lot of numbers already, but it needs to be tracked on the way through. So we've got that hard objective data that we measure, and then there's the softer subjective data that is someone's own experience that we touched on more last week. But that all has to come together, and when you sort of build out that view, you can get a really nice snapshot to see what's happening, where are we now, and how have we been moving over the past X number of weeks. One thing that I wanted to touch on with you is that I think we'll cover off on a few of these points is on episode 2, I think it was, when we were talking about pathology and we were talking a bit about fibrosis. One of the things that you mentioned is when testing a straight leg raise, as you've sort of progressed in your experience and your skill sets, it's getting a lot more sensitive now in terms of the information that you're getting when you're performing this test, in terms of what the patient is telling you and your understanding of that, mapping it back to what's actually physically going on. So if there's entrapment, you're already starting to think exactly where that might be. Take us through that a little bit. So maybe let's use the straight leg raise as a test that we collect data from, and how we map that up with the patient's experience and what they're telling us through the test versus the more clinical data that we're getting, and how that picture comes together.
Yeah. So when we look at, first of all, before I'm even testing anything, I've got my list of, even if it's a lower back pain patient, just from the history, I've got my particular ones within that set, kind of at the forefront of my mind. So I'm thinking, what's based on what this patient is telling me of the 6 lower back tests that we do, which ones am I going to not necessarily particularly pay attention to, but which ones am I already kind of suspicious of? So, you'd have somebody that's complaining of either lower back pain or hip pain that's kind of radiating down the leg a little bit in kind of a numbness and tingling manner, or they're complaining of, lower back pain while deadlifting, or, any variety of, I guess, symptom sets or complaints or aggravating factors like that. So when I start to get that's when I start thinking, okay, this may be some pathology that's related to a straight leg raise. People who complain about lower back pain with things like squatting, it's not so hot on my list of suspicious tests, but sometimes those suspicions are 100% incorrect, and so you measure everything anyways, and you shock yourself at times. So when you're looking at a straight leg raise, it is just what that is. It's a straight leg raise test, and we're essentially measuring, a couple of potentially different things. First of all, how well is your sciatic nerve gliding through the spaces that it needs to glide, like dental floss? So that's usually, I don't want to say usually, but that's what I'm kind of looking for with the straight leg raise. In particular, statistically speaking, if your straight leg raise is limited, that's what's going on, at least in terms of the differential that I can tangibly fix. You're also looking at adhesion in the actual hamstring bellies. And you could also have a space-occupying lesion in the lower back. And so something serious like that is going to measure at a different magnitude than a typical straight leg raise. It's going to come at a different symptom subset than what we're typically looking for. So if you go to raise somebody's straight leg raise and they're complaining of pretty intense pain before we even get to 45 degrees, I'm starting to think that may be a hot disc or space occupying lesion. But when we continue that test, so say we've ruled that out, we've gotten their leg to 50 degrees or 60 degrees, I'm looking at now trying to differentiate between nerve entrapment and adhesion of the hamstring. And we would do that by taking the test to end range and basically putting tension on the nerve. And if putting tension on the nerve increases the symptom set, then we're thinking nerve. If it doesn't increase the symptom set and they still have a focal point, symptom set, then thinking more hamstring. And does that kind of answer your question?
Yeah, I think an important point with this one is that it classically is used only as a nerve root tool, as a disc herniation tool. That's how it was taught to me in orthopedics, and that's how I've really only heard it being used before. And typically, I think if it stops shorter, it's generally looked at as being tight hamstrings, which is sort of the case, I guess, because the hamstrings couldn't kind of block it, but it's like, why aren't they moving? So we look at it in a way that we get more information from it. And I can't really think of a time where I've used it that it has really had that hard block of a disc being involved. I think most, probably 99, maybe 100% of the time it's been to do with the sciatic nerve not being able to move properly. And it's a huge problem. What's the percentage you think of low back cases that have some sort of involvement in this that you've seen? I think it's a really high percentage.
Well, some sort of involvement differs from primary, limiting factor, but some sort of involvement, be hard pressed to say anything less than 50%. It just depends. I mean, that's a tough question to answer. It is an issue in a large percentage of individuals. Again, whether that's the thing that I go in and dive at first, that maybe happens 10 to 15% of the time. But yeah, I mean, the straight leg raise gives you wonderful data, and we measure it in a way that's different than 99% of practitioners out there. And, you know, that's why perhaps we fix those people that can't be fixed by other people, because we are looking for that. I mean, it's in the grand scheme of musculoskeletal health, it's pretty flippin' common. So.
Yeah. And so this test, it gives a lot of information, because once you take that straight leg up, the first thing that someone usually encounters is they get a lot of tension behind the knee a lot of the time. That tends to be where you feel it, or you feel like your hamstrings pull tight. And that's the sensation that you get. Some people feel that tension in their calf. Some people feel it anywhere between. Some people get some tension in their foot. And that's because we've got this continuous neural tissue that runs all the way through. So when we're doing this test, it's not just necessarily to take your straight leg up and see if you get back pain, and if not, then you're good. We're actually really interested in where that tension develops. We're interested in the severity of it. Is it mild? Is it moderate? Is it really quite severe? And then we're going to challenge that a little bit too, to see if it gets worse, or does it get better, or does it move? And so all of these things are data points that we're measuring, and it's all going onto a form or a whiteboard, or we're doing something with that, because post-treatment or on the next visit, that's the sort of thing that we need to compare, because if we're doing our job properly, then it should be changing. And so the actual angle that we're getting to in that range of motion, we're going to be measuring that in terms of degrees. So there's a number that's associated with it. And then we're going to be marrying that up with all the softer data that the patient is able to tell us in terms of what they're feeling. And that whole picture is something that we compare at the next time. And so there's a progression. You start to see these things change. Usually you see that number getting better. It's a better angle that we're getting. Usually we're seeing maybe the location of the tension is starting to change a little bit. It's starting to perhaps move a little bit further up the chain. And generally the intensity of that is starting to come down as well. So that's what should be happening if we're doing our job and if things are going well. And so if you're not doing that, and if you're trying to eyeball that, and we're just putting the leg up and we're having a look and going, I think it's about 80 degrees. Trust me, it's not, because I did that for a little while, and it's so much different to what you think it would be. And those small degrees can matter. You know, there is a bit of variability in between checking this and between visits and those sort of things, but that's why it's important to check. But if you're just eyeballing it, you know, what do they say? If you're not measuring, you're guessing. But man, it's true, right?
Yeah, absolutely. And yeah, we kind of glossed over the fact that it's a metric of effective treatment as well, right? You can use measurements as metrics of effective treatment. And you know, I'll give a personal example that I actually experienced myself. And you know, I was getting treatment done, and you were there, right? This was in Boston a few months back. And, you know, I had a limited straight leg raise. I think it was, you know, 77% or something like that.
Yeah, I remember. This was your sciatic nerve that didn't want to move through the hamstring.
Sciatic nerve didn't want to move, exactly. So my sciatic nerve was trapped. And so everybody measured at the beginning of the seminar, measured at the end of the seminar. And everybody got these like wonderful, tangible improvements. And I was like, oh, shit, I had 77 when I started and 78 when I began, which is, you know, not big enough to be a positive data point. And so we had the instructors come over, treat me, no change. So they're at the level where if they get no change, it's not because they performed bad treatment, it's because they're wrong about where to go. Well, not wrong, but, you know, they guessed wrong in this instance because it's not a purely clinical setting. You know, I didn't get a full exam. And, you know, I ended up having my sciatic nerve trapped to, I don't know if I want to call it, basically the posterior edge of my adductor magnus, which happens in like was it 1% or 0.1% or something ridiculous like that. So, by using that measurement and saying we're not doing anything, in the case of a normal clinic, you might go 5-6 visits of not doing anything except handing them your credit card or your insurance information. But because we had such amazing data, we were able to kind of assess that real time. And they were like, well, you're not leaving until we make a change. And they just kept going down the list of triage until they were like, oh, that stuck. So it can't be, I can't stress enough from a personal experience how important that data is.
Yeah, I remember that happening. I remember you were probably a little bit frustrated, I think, because we were going around the room and we were rerunning some numbers in terms of where we'd started and what we'd been able to achieve over the weekend. And there was some pretty impressive numbers coming up, and yours hasn't really changed. And I think the comment was, I've got a very stubborn hamstring or something like that. But there's answers to these things. And so it takes a little bit of persistence and you're able to get there. So it's, it was a nice way to close that out.
Yeah. And we can, one of the ways that I personally use the data in my own clinic too, and I never like to do this, and I never like to admit it, but, sometimes we're not helping people. And it happens in cases that are, rarer than the average practitioner. But like we've discussed here, it's like there's nowhere to hide. So say you came into my clinic and I'd never looked at the posterior border of your adductor magnus for a sciatic nerve entrapment, right? So basically a big nerve getting stuck to a deep muscle in your hamstring. I'm not going to let you go 5 visits. You're not going to let anybody go 5 visits. Usually the rule that we like to uphold is 3 visits. And while we hate to not get you results, I think what we hate more is lying to ourselves and convincing ourselves that we actually are helping you when in reality we're not. So, for me, I'm more, because I have the measurements and because I'm armed with such great objective data, I have no issue, outside of maybe the ego sting of saying, hey, I'm not helping you. I wish I could. I don't know who to send you, but if this is a waste of my time and a waste of your time, then we're stopping. And that's that. So doesn't happen often, but when it does happen, I like to sleep well at night. And I like to sleep well at night knowing that I've done what's right for you.
Yeah, I like to sleep well at night too. Who doesn't, right?
I don't, psychopath.
But look, it might be a very, very low percentage, and you sort of hope that you don't have to have that person come in. But if they do come in, and let's just say they've got a lot of pain, or they've got a pretty significant problem, but their functional tests are all passing, and you're not really able to put a finger on what's going on from a mechanical problem. To be able to measure that and to be able to show them that, hey, look, your range of motion and your function is fantastic, but you've clearly got a problem here, to be able to say, I think we need to get you somewhere else because this could be potentially more urgent, or it could just be that this is not the right place for you to be spending your money. The worst of those scenarios, that could be quite significant to that person, to get them out of there quickly and to get them to the place that they need to go. And so if you don't have the specificity to be able to do that and to be able to show that, to be able to get them on board as well, that could be huge.
Yeah, I'll give you a patient example of mine. I had a very, very dear friend of mine come in and complain of hip pain, and I was really, really excited to help her. I'm going to be the guy right now. You know what I mean? Came in, was complaining about hip pinching while doing burpees, which is not something that you typically get, right? So all of a sudden, right? Yellow flag for me. Something like an air squat even, got her to the point where it was like 9 out of 10 pain. She had to sit down. I'm like, this is interesting. Take her to the exam table and go to test her hip flexion, right? So basically bringing her thigh to her rib cage full with a pinch at the end, a pretty uncomfortable pinch at the end. And at that point, it was like, I'm not it for you. This is just completely not it. And, you've got a torn labrum and you need to go see an orthopedic specialist. And, you can kind of come in and we can give it a visit or two because you're my friend, but I'm not optimistic in that working. And, then the unfortunate thing of the American medical system comes in where she goes to the orthopedist. The orthopedist has to give her 6 weeks PT before the orthopedist can order an MRI, and then the orthopedist orders an MRI, and now finally we can start moving down the path of surgery. But you can use those measurements to give you powerful data, as to whether or not you can even help somebody. There's individuals that come in with torn rotator cuffs all the time, and we see that and we say, that's not me. We may be able to remove 5 to 10% or we may be able to improve that function 5% based on some of the very, very, very level one, very mild adhesion that I feel in you. But this is unequivocally a surgical case. You get an older individual in and they come in with 30% function in the lower back, probably thinking arthritis in there too. So that data gives us not only information as to how we're progressing, but information as to whether or not we are even, a good fit for each other, and whether or not we continue to remain to be a good fit for each other.
It's how you do your job, isn't it? It's how it should be.
No other job. I mean, who doesn't have a quarterly review where they go over the metrics in your job? Who doesn't, what professional sports team doesn't review statistics? Anything, right? Anything that matters in any way, shape, or form, we've devised some way as human beings, because we recognize how feeble and insecure and insignificant our brains are. We've devised a way to create some sort of measurable data. It's literally CrossFit in a nutshell. CrossFit in a nutshell is we've found a way to devise tangible data and show improvement, and we found a way to play to your primal insecurity of wanting to belong to a tribe. So boom, right there, that's what's magical about CrossFit right there. What do you think is magical about SoulCycle? What do you think is magical about the Peloton? It's like we have this beautiful, clean interface for where we can put everything on a graph and you're good. So why are we any different as a subset profession than human nature? So it's like, what makes us so special that we can sit here and be like, well, let's do 3x12 McKinsey extensions, and when you're feeling good without any measurable objective progress, we'll either discharge you or say you need to come in every 2 weeks for the rest of your life. It's human nature. That's why it's a principle.
And on that note, what a nice way to wrap us up. Look, you're 100% right. I think this has to be at the core of what we do, and hopefully to push a profession forward because of the transparency that it brings. And it's just it's a good thing. So
and if you're a patient in any sort of medical system or visiting any sort of doctor, right, these podcasts aren't intended for us to talk down about anybody or to get underneath anybody's skin. We want people listening to this to understand what makes a physician or practitioner good and what makes a physician or practitioner bad or less than ideal. So whether you're listening to this in Adelaide, whether you're listening to this in back home in Woodridge, or wherever you're listening to this, if you have pain and you go see somebody and they do not give you measurements in degrees and they do not give you updates on how that is changing, then sayonara, right? Say goodbye, not because you don't like that individual, but because they're missing out on a valuable piece of data that's going to make you better more efficiently. So, I mean, that's what the intent of this podcast is. Yeah, we like talking about measuring our dicks, and yeah, we like talking about flat earth and being bald, but the real intention of this podcast, pretty much just said measuring dicks, but the real intention of this podcast is to provide you with enough information to where you can make educated decisions as to what type of practitioners that you see. Right? This is not designed for Sydney people or New York people to come in and see us. It's designed for you guys to find people similar to us because we know that what we do is the right way to do it.
Yeah, it's just to shine a light on the fact that it exists, I think, because not enough people know, and not enough people that operate in our space know that this is even a thing. And, I think a lot of us find it by chance. You ask people, how did you sort of fall into this space? And, the stories are usually similar. They're usually individuals that are looking for answers, and by chance they kind of find it. But if we're in that space already and we're not finding it easily, how the fuck are patients going to find it?
Right.
So if there's anything that comes out of this, apart from a bit of fun that we get to have every week, I hope that it is informative to someone that needs it, that they can actually reach out, whether it's to us or to someone else, or that they can start asking the questions that they should be asking and find what they need. And if that does one good thing, whether that's over here, over there, or whoever hears this, then I think that's it's been worth it. So, we're going to keep doing it because it's a lot of fun, and hopefully it's a little bit more successful than CrossFit, which just kind of shit itself and burned recently. But look,
an iteration of CrossFit has shit itself.
Right. So look, yeah, we'll see what happens. But I think you're right. I think hopefully we're just doing this for the right reasons, and maybe it'll reach some people one day.
And it's urgent too, because without good healthcare, your body is as healthy as it will ever be at this current moment. Otherwise, you are slipping and degenerating and tumbling into an endless vacuum of chaos, right? Entropy. So don't listen, whatever the heck you want to do, but we're trying to give you as many gems as we possibly can so that you can enable yourself to be healthy and happy.
What a great way to close it out, being healthy and happy. Can't ask for too much more. You stay safe out there, Dr. Mike. We'll see you soon.
You too, brother.